Malignant esophageal tumors. Squamous carcinoma accounts for the majority of esophageal carcinomas worldwide. Adenocarcinoma of the esophagus, once an unusual malignancy, is diagnosed with increasing frequency and now accounts for more than 50% of esophageal cancer in most Western countries. Esophageal cancer can cause progressive dysphagia, which results to weight loss and malnutrition. It is common in the middle and distal third portion of the esophagus, and treatment depends on the stage of the disease. These are the risk factors for developing esophageal cancer. The most important etiologic factor in the development of primary adenocarcinoma of the esophagus is a metaplastic columnar line or Barrett's esophagus, which occurs in approximately 10 to 15% of patients with gastroesophageal reflux disease or GERD. This slide shows the AJCC definitions of the primary tumor, lymph nodes, and distant metastases. Tumors that arise within the middle third of the esophagus are squamous carcinoma, most commonly and are frequently associated with lymph node metastases, which are usually in the thorax, but may be in the neck or abdomen and may skip areas in between. Tumors of the lower esophagus and cardia are usually adenocarcinomas. Treatment for esophageal cancer. Still, surgery is the mainstay of treatment. The surgical treatment of esophageal cancer is dependent upon the location of the cancer, the depth of invasion, lymph node metastasis, the fitness of the patient for operation, the culture and the beliefs of the individuals and institutions in which the treatment is performed. Currently, the use of radiotherapy is restricted to patients who are not candidates for surgery, and it is usually combined with chemotherapy. Radiation alone is used for palliation of dysphagia, but the benefit is short-lived, lasting only 2 to 3 months. Radiation is effective in patients who have hemorrhage from the primary tumor. Chemotherapy is used either as neoadjuvant or adjuvant setting in concurrent with radiation therapy, depending on the stage of the patient. This is the suggested global algorithm for the management of carcinoma of the esophagus. A good clinical evaluation must be considered. A pre-op diagnostic is essential in arriving the stage of the disease. A biopsy is required through endoscopy or bronchoscopy. Further workup include chest and abdominal CT scan, endoscopic ultrasound, MRI, and chest X-ray. Esophageal perforation. Perforation of the esophagus constitutes a true emergency. It is most commonly occurs following diagnostic or therapeutic procedures. Spontaneous perforation accounts for only 15% of cases of esophageal perforation, foreign bodies for 14%, and trauma for 10%. Pain is a striking and consistent symptom and strongly suggests that an esophageal rupture has occurred. Spontaneous rupture of the esophagus is associated with a high mortality rate because of the delay in the recognition and treatment. Diagnosis of esophageal perforation. Abnormalities on the chest radiogram can be variable and should not be depended upon to make the diagnosis. This is because the abnormalities are dependent on three factors: A. The time interval between the perforation and the radiographic examination, B. The site of perforation, and C. The integrity of the mediastinal pleura. Mediastinal emphysema, a strong indicator of perforation, takes at least 1 hour to be demonstrated and is present in only 40% of patients. Chest radiogram showing air in the deep muscles and cervical emphysema of the neck following perforation of the esophagus. This is often the earliest sign of perforation and can be present without evidence of air in mediastinum. The integrity of mediastinal pleura influences the radiographic abnormality in that rupture of the pleura results in a pneumothorax, a finding that is seen in 77% of patients. In two-thirds of patients, the perforation is on the left side. The diagnosis is confirmed with a contrast esophagram, which will demonstrate extravasation in 90% of patients. The use of a water-soluble medium is preferred. The studies should be done with the patient in the right lateral decubitus position. In this, the contrast materials fills the entire length of the esophagus, allowing the actual site of perforation and its interconnecting cavities to be visualized in almost all patients. The key to optimum management is early diagnosis. The most favorable outcome is obtained following primary closure of the perforation within 24 hours, resulting in 80 to 90% survival. Mortality associated with immediate closure varies between 8 and 20%. After 24 hours, survival decreases to less than 50% and is not influenced by the type of operative therapy, meaning drainage alone or drainage plus closure of the perforation. If the time delay before closing a perforation approaches 24 hours and the tissues are inflamed, division of the cardia and resection of the diseased portion of the esophagus are recommended. The patient will have an end cervical esophagostomy with a feeding jejunostomy tube. Non-operative management of esophageal perforation has been advocated in celiac situations. This course of management usually follows an injury occurring during dilation of esophageal strictures or pneumatic dilations of achalasia. Conservative management should not be used in patients who have free perforations into the pleural space. Cameron proposed three criteria for the non-operative management of esophageal perforation. A. The esophagram must show the perforation to be contained within the mediastinum and drain well back into the esophagus. B. Symptoms should be mild. And C. There should be minimal evidence of clinical sepsis. If these conditions are met, it is reasonable to treat the patient with hyperalimentation, antibiotics, and cimetidine to decrease acid secretion and diminish pepsin activity. Oral intake is resumed in 7 to 14 days, dependent on subsequent radiographic examinations. Thank you and good luck.